Right now.
Oh, there is a
Yeah.
yes,
Yeah.
because when I first, I'm like, who's this? You're right.
Yeah.
That's crazy.
Yeah.
Crazy.
That's interesting.
Yeah. Yeah.
Someone really went out of the way.
I did. And she said, who am I? We liked it too.
Yeah, thank you. Thank you for the invitation.
Eric, this is Simeon.
Hi.
He's from CMS. So he's the lead for the So here we go. It's like career contribution of all that good stuff. No, Dr. Lynn, did you want to sit up here? Maybe that'll do that after I say my word. Okay.
Yep. Exactly. What's that? No, but I do like that.
Are we ready? Oh, Dr. Karlawish is here.
I do remember. Left.
Is everything ready to go? Okay. Good morning, and welcome to CMS's 2018 Data Privacy Day. I'm both excited and relieved about our program today. Excited because I think we have a great group of presenters here to talk about a really compelling topic, and relieved because it's never easy to pull off an event like this. And when you first choose the day of like the shortest federal government shutdown in history, and then you choose the Ides of March, you realize that you can't take anything for granted. But the stars have aligned, and we're all here today. And if anything weird happens, you'll all know that there's some other force behind it that caused it. So welcome to one and all in the room, and to those of you watching on YouTube, and those of you who have called in. And thank you all for taking the time to join us today. This year, the Data Guardians have the distinct honor of sharing this event with two of our sister components, the Center for Clinical Standards and Quality and the Center for Medicare and Medicaid Innovation, to bring you a discussion about aging, cognition, and data sharing. As we started talking to people around the agency and told them about this topic, we found that everyone was really interested in it, and it seemed like everyone had a different reason. But as catchy as the title is, and as nice as the posters and graphics are, you still might be wondering and asking yourselves, what does this topic have to do with data privacy or the Data Guardian program? And that's a really good question, because so many people think of security and privacy and the data guardians as those people that are just going to tell you that you can't, and you have to do something that costs a lot of money, and it's hard, or it might take a long time. And we're that group that tries to trick you into clicking on those little links in the phishing emails. And I think that sometimes people think that because the data guardians have become known for phishing exercises, and we talk a lot about cyber threats and ways that our emails and systems can be compromised or hacked into, that all we're going to tell you is don't click on that link and don't open that attachment. I'm here today to let you in on a little secret. We're here to help you understand how to use data to make your programs successful, to fulfill the mission of this agency, and to serve the people who rely on CMS for their healthcare coverage. And what I'm passionate about, and what my staff is passionate about, is using data and information properly, because data is like a diamond, and when it's used properly, and we're transparent, and give the people who are the subject of that data enough information to make informed decisions about how their personal information can and will be used, then that diamond gets polished, and the real value of the data can be appreciated. So back in November, when George signed my travel documents so that I could participate in the first meeting where this group of presenters met at the Federal Reserve Bank, he must have wondered, what is she doing now? Any other CIO would probably have looked at the name of the event and thought, what does this have to do with our work with IT systems, and why is she going to this conference? But when I came back and we started talking, and I talked about wanting to organize this event and how important it is for us to understand the need for our beneficiaries to be able to grant safe and secure access to share their data, not just with their healthcare providers, but with other community, family, and social service providers, that they authorize to have access to their information, he was interested and engaged. George, you understood what this was about, and your support and encouragement has been a real motivator for me. Thank you. With George at the helm of the Office of Information Technology, it's clear that we have entered into an era where CMS is maximizing the power and value of our technology and our technology investments. Technology is a powerful tool. It has the potential to connect us, and at the same time, it can create isolation. It allows people to be alone while being connected or together. For many of us, our meetings have become virtual. And we have colleagues who we work with regularly who we have never met in person. Over the last year, I don't think anyone that works here at CMS can say that they haven't noticed the improvements in our ability to connect to the internet, or to stay connected when we move around our building or go to satellite offices. The improvements in the end user experience have made it easier and quicker to join meetings and be productive. It makes it easy to imagine how important the role of the Office of Information Technology will play in meeting the challenge of developing programs, tools, and applications for the up-and-coming next generation of Medicare beneficiaries that are tech-savvy, that Seema Verma talked to us about just a few weeks ago. So join me in welcoming the Director of Information, the Office of Information Technology, and CMS's Acting Chief Information Officer, George Hoffman.
Well, thank you, Karen. So I'm actually very happy to be here because, like Karen, I felt like maybe we soloed under some kind of unlucky star that said that this meeting would never actually happen. But hey, we're here. It's happening. So I'm actually very happy. One of the things that Karen and I spoke about back when we were preparing the first time for the event, we had this conversation about how technology can connect dots, right? That we can connect the dots not just for technology's sake, but because there are innovative ways that we can deliver care, and thinking about technology and how it can actually help us in that regard actually opens the door to a lot of cool things that can happen. And so we started talking about technology and saying, well, how has technology made a difference in how CMS does what it does? And so I started thinking about technology in general, and we had this conversation about, you remember, or maybe you know or are, a person who has heard stories from, you know, your parents or whatever when radio was first created, right? You know, what happened when radio first came online, you know, and people could have a radio in the home? What would happen? Well, they would all like gather together and they would listen to the radio, and, you know, everybody, that was like the thing. That was what you did. It was like, ooh, you know, that was your connection to the world. And it wasn't on all the time. It wasn't always, you know, available, but, you know, programs had specific times everybody like tuned in because you want to know what's going on. And then it created this opportunity for all these conversations to happen after, right? You were exposed to something, and then like people would talk about it because that was it. That was it. You know, it's like, wow, you know, your reach, you know, in your personal life back then might have been pretty small, you know, small setting, maybe you interact, you know, maybe you get a newspaper, but radio was like across the world, you know, this is really cool stuff. And then the television was invented, right? And so then people started getting together and, you know, oh, you're going to watch TV, you know, the Ed Sullivan Show or whatever, yeah, I don't know, that was before my time, but at least I've heard about it. And that's what people did, and then they would talk about it forever. So, you know, technology started to kind of bring people together, and that's kind of a cool thing, right? Because that's what we're hoping that technology can do, kind of bring people together. But then, you know, technology started getting better, right? You know, it started getting cheaper, it started getting more portable, it started getting more capable, and so what happens, you know? Oh, I don't need to hover together as a family because now I've got 2 TVs or 3 TVs, or everybody's got a TV in their room, or now they have it in their pocket because they can pull out their smartphone, you know, and they can have access to this. And, you know, technology is cheaper. Well, okay, maybe not current generation smartphones, because I guess, you know, Android and Apple are having this competition to see who can have the most expensive smartphone. But the capabilities that exist through this platform are really something else. Now the only time that my family actually gets together is to argue over whether YouTube or Netflix is being the bigger bandwidth hog on the home Wi-Fi, right? They're not actually together sharing in the experience. Everybody's off having their own experience, you know? So when we look at technology, you know, there are good sides of it and there are bad sides. Like Karen said, you know, it can make people be isolated and then come together for all the wrong reasons. You know, arguing about bandwidth or data usage, right? If you're on a family share plan, you know what I'm talking about. And if you have, you know, kids like mine who like to be online all the time, that's an issue. But think of it, you know, we're trying to make sure that we look at the plus side. How does technology actually enable and make things better? And, you know, figuring out how to connect those, you know, innovations in healthcare with the platforms that we have is really what we're all about. And like Karen said, you know, we've been focusing on making a lot of improvements around CMS over the last year. The cool part is that between our Wi-Fi upgrades and the changes to our VPN capability, you can actually be connected everywhere in a CMS facility or at home, and you can work all the time. Okay, so all the managers were like, yeah, and all the staff was like, great. Or maybe it was the opposite. I'm not 100% sure, but that's what we are doing, right? We're making it so easy. We're making technology so available. So the plus side is, you know, hey, I can work all the time. The downside is I can work all the time, right? So I have to figure out where that balancing point's going to be. I can't just let the technology kind of rule. And you know, the fact that we have this always connected kind of mindset. It means that we have to come up with some new rules, some new normal, right? I mean, I think most of us still like to get at least a couple hours of sleep a night. So at some point, you have to put the email down. You know, it's great that if I have a thought at 10 o'clock at night, and I can go, Janet, da 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 da, and guess what? 90% of the time, okay, you know, it's like, wait, why were you reading your email? You know, it's like I didn't intend for you actually to respond at 10 o'clock at night. It was just, you know, I wanted to get the idea out there. And so it's like we wind up in this always connected, always on. So how are we going to create, you know, policies or expectations where we can start to put boundaries around that? You know, one of the other changes that we've done, you know, we are making a big upgrade to our VTC system, right? That's this video teleconferencing capability that we have. Well, that's fantastic because now we're not only opening it up so that we can connect to other endpoints, so like sister agencies. Right now our VTC is a closed system. We're trying to open it up, make it available to people at an endpoint, so you could be at your desk at home, and you can actually participate in the meeting. You can actually see the people that you're talking to. You can interact with them. So that's capability that we're working to bring online. Well, what's the downside? Well, now you're on a conference call and you roll your eyes. Our cameras are really, really sharp, and they will pick that up. And they will know that now you're eye rolling. Oh, wait, that's a whole new normal, Instead of looking at the black box, you better look at the camera on the screen because it's watching you. And that's a good thing, or it could be a bad thing, right? So what is the normal that we're going to use with that technology? And so, we have this connectedness. And as we're looking at the concept, for me, of aging, cognition, and data sharing, saying always on, it's really interesting. So just a story for you guys. This week, my family was very interested in doing Ancestry.com, right? My daughter's convinced that, no, we have to be from here because, I look like this, so it's got to be true. And I'm like, all right, fine. So we ordered the kits. And I'm watching, you go through the whole thing and having to fill that stupid thing with spit. I know it's a little disgusting, but it takes a lot. And I was like, wait, how do I do this? But we went through it, and then as we're signing up, you have to go online and you have to activate the kit. Well, the interesting thing is that as you're activating the kit, you say, okay, here's my email, I sign up for an account, da-da-da-da. What do you want to do with your results? And I watched my wife and I watched my daughter, and they went click, clickety, click, click, click. You just said you were going to share everything about your background with everybody. Did you know that? Oh, no. Ooh. Okay. So you went the easy path, which was cool. You're trying to get connected, which is also cool, but do you know what you're actually putting out there? Did you know what you were making exposed? So sometimes, people like me, I was like, no, 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 no. Okay, yes to that one because I want my family to know. But I looked at it very, very differently because I have a slightly different lens, right? When I think about my parents and I think about the fact that, as they were going to doctors and they were getting information and they're not even aware necessarily of the decisions that they were making. And then I watched the, quote, more modern generation do the same thing where they were willingly giving away their information to whoever wanted to see it. I said, this is really interesting. It's great that we have this technology, right? It's cool. We could wind up being connected with people we don't even know about. But did they know what they were giving away, right? Did they understand the gravity of what they were about to share and why they were sharing it? And, and this started a conversation about Facebook and, whether you share everything with everybody or whether it's just friends or whether it's, whatever. And all of a sudden it's like, okay, we've got people who maybe in the back of their head say, oh, I would never share my ATM code or my bank account number, but they're not really being aware of what they might be sharing with with respect to their medical information. And so we wind up with this, kind of technology savvy generation who's coming online, but maybe they don't have the awareness that they need to understand the implications of having that tech available to them, right? And the old adage, hey, you can do things to screw up, but if you really want to screw up, you need something automated. Well, if you put that on my smartphone and I don't really know what I'm signing up for when Google Health or the latest Apple app says, would you like to share all of your information so that way, it can connect all these apps? I think we need to have some guardrails put up, right? I think that what our role is not just to make the technology available, but we have to come up with the ideas and the concepts and the policies so that we can educate people so they know what they're doing. Enable the capability, which I think is great. I think the technology that is available to us, as Seema talked about at HIMSS last week, it really is pretty cool, but we have to make sure that we are putting up the guardrails as appropriate. Because, there's like in my head, I have this curve of technology advancement, my ability to make good decisions, right? And so at some point in my life, those lines are going to cross where I will no longer be making the best decisions, but I will have the capability to do so and share. And understanding what the implications of that are is why I'm actually very excited to be here today. Because when I look out and I see that we have a bunch of people in the room and we have a bunch of people online that are interested in taking privacy and this concept of, data sharing and how well are we making decisions about our healthcare, how well are we making decisions about what we're doing with our data, I actually feel encouraged because I know that there are some people who are going to have my back, right? So when I'm the guy who's making the poor decision, I will know that a bunch of people like you are working on my behalf so that I hopefully at least have the opportunity to plug in and understand. So I think as we get into this conversation today and we talk a little bit more, I really hope that you guys can recognize the fact not only are you helping to lead the agency, but we're actually setting an example for the whole nation on how to do things and do things well. And let's continue to work on this topic because it is tough, just because you can, should you? And let's make sure that we have those people's backs who maybe aren't in the best position to make the decisions for themselves. So anyway, wanted you to enjoy the day. Thanks for the opportunity to check in, and please let's make sure that we are interactive. We have some really cool speakers that are going to talk about some topics. I know there's a way for us to, hopefully, get a chance to do some Q&A, but take advantage of it because, in the questions that we ask and the interaction that we have, I think we can really make conversations like this come alive. So thanks, and enjoy the day.
Next, I'm honored this morning to introduce Dr. Sherry Ling. I want to thank Dr. Ling. I sat next to her at a data governance board meeting a few months ago, and we briefly chatted before the meeting began. We shared some ideas about the value and richness of our CMS data, and we talked about some research that's being done by a former Grand Rounds presenter who is a personal friend of mine, who used our data in his research. And Dr. Ling graciously agreed to partner with us and is sharing the Grand Rounds Forum this morning. It's my pleasure to call on Dr. Ling to introduce the Grand Rounds portion of our program.
So good morning, all. I first want to say thank you to Karen and to George and the team for actually including CMS Grand Rounds as a portion of today's events. As difficult and challenging as this day was to plan, I think it's actually symbolic of how challenging it is, the problems that we have to solve in order to meet the needs of people with cognitive impairment, dementia, those who are at risk and don't know they have cognitive limitations yet. One of my duties as the Deputy Chief Medical Officer here at CMS is I have the honor of serving as the federal lead for the Clinical Services Work Group for the National Alzheimer's Plan. And over the years, it has become really apparent that as we use all of the program and policy levers that CMS has the authority to implement to support the national plan, that is, achieving effective care and management for all persons with dementia by 2025, we actually have made significant progress in the inclusion of cognitive impairment in the annual wellness visit, in being able now to provide reimbursement for cognitive assessment in the context of a care visit to clinicians. The challenge that we have, and I'm a dementia care provider in the VA health system, the challenge that we have is that we are still working within the walls of healthcare service delivery. And the patients that I see, the people that we know that we serve, live outside of the walls of healthcare service delivery. And it is our hypothesis that we can identify and use data that can then become information that can help predict who may have cognitive impairment and challenges, and to be able to then translate detection into a clinical scenario that results in a diagnosis and better management. So that this event today, this Grand Rounds event, is included in the Data Privacy Day is really, really a unique opportunity, so I appreciate that. So our topic today is examining cognition and value of information sharing to identify and address health-related and social financial issues. This actually is a very broad topic, very focused at the same time, just illustrating some of the opportunities and challenges that we have. As part of CMS Grand Rounds, we offer credit for continuing medical education and CEUs for our nurse colleagues. And to support this, we have stated the following objectives: that the learners will be able to describe how cognition changes over time with age and impacts financial health, list some examples of economic impacts of cognitive impairment, and describe how accountable health communities, this specific model, addresses health-related social needs through clinical community service partnerships. So really cutting-edge work that we are delighted to hear about today. This also aligns with several of the CMS strategic goals, in particular, really supporting innovative approaches to improve quality, accessibility, and affordability, as well as empowering patients, people, and their clinician teams to make decisions about their health, about the health care. So this is actually using information thoughtfully in the care and keeping of the people that we serve. So all of CMS events are actually eligible for CME and CEU credit, and to earn that credit, you simply go to the appointment that is on your calendars and follow the instructions there. We recently have changed the process by which CME and CEU credits are delivered, but you do need to answer the evaluation questions correctly to earn that credit. And just by way of disclosure, this presentation has been prepared as a service to the public, and is not intended to take the place of either written law or regulations, and any reference to CMS policy by any speakers is really an expression of their own opinions and should not be viewed as official CMS policy. We do have a couple of upcoming events that I would like you to note. You will be receiving global appointments for these, so stay tuned. And with that, I am actually honored to introduce, we have two speakers today. The first is Dr. Jason Karlawish, who is a professor of medicine and medical ethics and health policy and neurology at the University of Pennsylvania. And his research actually focuses on the ethical and policy issues encountered by older adults with late life cognitive disorders, including Alzheimer's disease, and has also developed the assessment of capacity for everyday decision-making, which is an instrument that has predictive value that we will hear about today. So really welcome Dr. Karlawish. Our second speaker will be our colleague from the Innovation Center, Simeon Niles, who is in the Division of Population Incentives Infrastructure and in the Prevention and Population Health Group at CMMI, and has been a leader in population health and the creation and implementation of the Accountable Health Communities model from the start. So welcome, Dr. Karlawish.
Splendid. The green button is go, which means at some point someone will push the red button to stop me. It's a pleasure to be here. First I want to just thank you for Karen for your initiative to make this conference possible, this Grand Rounds possible, the topic. But more broadly, I want to just thank CMS. I want to thank Medicare. I'm a physician. I'm a geriatrician. Tomorrow I'll see patients at the Penn Memory Center, and they're all going to be Medicare beneficiaries, and I'm a geriatrician, and what you do is like you give me the air to breathe or the water to drink, and it's essential. So I wanted to just take the opportunity to thank CMS, thank Medicare for being what you are and making my practice possible on behalf of my patients and their families in particular. So I wanted to pick up George Hoffman's point. So tomorrow I'll be seeing patients at the Memory Center, and in fact on the ride over here I took out my smartphone and logged into Epic, the medical record, and looked up the patients I'm going to be seeing tomorrow, reviewed their charts, refamiliarized myself, saw that I had a new patient coming in tomorrow for a diagnostic evaluation at the Penn Memory Center, looked up what studies she's had, past visits, try to get a sense of what might be going on. And did that while someone was driving me, with a smartphone telling him how to get to here. Marvelous. And yes, George is working all the time. And it's an example, I think, of the power of technology. And yet, I don't think yet we're still there, because there's a little bit more information I would have liked, particularly for that new patient. And I guess I'll say it with a simple message, which is, I'm a doctor, but why won't my patients' bankers and other financial keepers call me to let me know what's going on? And the case I want to make to you is that we're missing a real opportunity to see the clear linkages between health and wealth, for both the diagnosis of cognitive problems, their treatment, and the management of some of the most important problems that follow as a result of having cognitive impairment. So that's sort of the roadmap for my talk today. I'm going to talk about how cognition changes over time, both as a result of diseases like Alzheimer's disease, but also aging. I'm going to talk how cognitive change impacts on day-to-day life, with a particular emphasis on our financial health and well-being. I'll delve a bit into the economic impact of cognitive impairment. And finally, I'm going to take a look a bit at the status of the economic health of older adults, 65 plus, 75 plus. And I hope by the end you'll start to see the linkages here. I guess I'll give you this preview point. In 1903, when Karl Dieter brought his wife Auguste to see a doctor in Frankfurt because she was just having such problems with behavior and function, the doctor interviewed her and interviewed him and examined her and arrived at a diagnosis of a dementia. She would go on to be the first case of the modern concept of Alzheimer's disease. He was Dr. Elias Alzheimer's. It's stunning, I think, that even today that's about the same as what I'll be doing tomorrow when I see patients in the Memory Center, and I think we can do things a bit differently, and I hope you come away with that. So I should point out that the talk I'm giving you adapts selective talks from the conference that Karen Mandelbaum talked about, which was Aging, Cognition, and Financial Health, Building a Robust System for Older Americans. And I want to thank my colleagues Patricia Boyle, Jeffrey Senzenbacher, and Craig Copeland, for who provided me some of the slides you'll be seeing today. So what do we mean when we talk about cognition? Cognition is just a way to talk about the brain's behaviors. And so when we talk about measuring something like, say, memory, it's just a behavior of the brain, encoding, say, a list of words, having several sort of distractor tasks that have you do something else, and then asking the person what were those words I asked you to learn before. And I could go through each of those domains of cognition. There's nothing preordained about them. There are creations. We decided that this thing called executive function developed valid measures and validated them, et cetera. And there are a host of different cognitive domains. I've listed the main ones up here. It's not just memory, obviously, is one of my points. What do we mean when we talk about cognitive aging? Simply put, imagine everyone in this room is gathered together, and a physician like me gets rid of everyone who has a disease that might impair cognition based on the current standards for diagnosis of a disease. Who's left, I would argue, are those who are, quote, free of a disease that could impair cognition. And then if I then have you come back every year and retest your cognition and re-interview you, whatever I measure, whatever I detect, I would argue is the effects of aging. As anyone develops a disease, I might pull them out and say, well, they developed a disease. But that change over time is what we would call aging. It should be obvious, therefore, that if I change the standards of what's a disease, I'll change who's in the pool of those who are aging, because they're going to be pulled out because they now have a disease. So it's a fluid construct, but it's cognitive function measured in the absence of disease. And for reasons related to how we measure cognition, the we have to adjust cognitive performance for the years of education someone has, because we don't want to just simply be construing it as those who are good versus not good test takers. And oddly, we adjust for years of life, which you'll see in a moment, maybe something we should rethink after the age of 50. And the key points I want to make to you is that over life, we observe changes in cognition. Some of those domains I've listed up there, like memory, etc., some of them kind of stay the same over time, but some of them change, even in the absence of disease, and change in ways that can be clinically significant. Certainly in the presence of disease, like Alzheimer's disease, those domains of cognition decline and obviously have significant functional implications. And so with this cartoon, I'm attempting to just kind of lay out the schema of the world, if you will, of the aging brain. That is to say, the brain that either is experiencing cognitive aging or the brain that is experiencing one of the most common diseases that affects cognition in aging, which is Alzheimer's disease. But it's, of course, not the only disease that affects an aging brain. Parkinson's disease causes cognitive problems. Lewy body disease does, etc. But we're going to focus on Alzheimer's here. So imagine on the x-axis is just years in life, chronologic years, and the y-axis is just an overall measure of cognitive function. Sort of take all the measures of cognition and add them up into one big score. Up at the top, therefore, is sort of normal cognitive function. We've got a couple people there, two people pretend on the far left, who at the age of 50 are showing up at CMS Grand Rounds, doing their jobs, etc. Time passes. The person on the top there is only experiencing cognitive aging, and I'll get in more detail in the subsequent slides there. I think a message is there's some changes that occur, okay, but not the significance of decline that you see in the other person in the yellow line who starts to experience and is showing changes in cognition that become clinically noticeable. Clinically noticeable is just my expression for meaning they come to the memory center and I either say that the problems meet the criteria for dementia, namely they've had at least a year of declines in cognitive abilities that are causing them to be disabled, difficulties managing their money, medications, driving, transportation, cooking, or mild cognitive impairment, cognitive problems that I can pick up on testing, the family member notices, the person complains, takes them a little longer to do things, a little longer to take care of the finances, maybe a few mistakes that are caught here and there, but generally getting on, not meeting criteria for dementia. Where one ends and the other begins is often a judgment call, a lot of noise there. I've put this phrase preclinical there. Right now we don't diagnose preclinical Alzheimer's, but a massive federally funded and private funded effort is trying to develop ways to validate the diagnosis of Alzheimer's before mild cognitive impairment. And Dr. Lang and others mentioned that federal effort. By 2025, it will be, we may arrive at a point in this country where it is possible to be diagnosed with Alzheimer's without being demented, without having MCI. I would argue that will only increase the importance of what we're talking about here today, namely, once someone's labeled, that they'll be monitored. I will show you data in a bit that even in that preclinical stage, though, we obviously pick up changes in cognition that can have clinically significant importance, but they don't cross into that threshold, that dimension of if you will, MCI. Okay? So that's the schema of cognition right now and the way we think about how cognition changes with aging right now in America. But let's take a closer look at cognitive aging. This is a scatter plot depiction. On the x-axis is age, chronologic age, 20, 30, 40, all the way up to 100. And again, on the y-axis is just a z-score of a z-score of cognitive measures. And what I'm trying to depict here is that we can take our cognitive abilities, our intelligence, which is the sum of all of our cognitive abilities, that's what intelligence is, and we can take that and actually divide it into two groups that we validated are legitimate, separate, distinct domains. The domain called crystallized intelligence or crystallized abilities, and then the domain called fluid abilities or fluid intelligence. Those are synonymous terms, fluid abilities, fluid intelligence, crystallized abilities. And what I hope you can see from these scatter plots is that over time our crystallized intelligence stays the same, if not even gets a little bit better over time. Whereas over time, with aging, our fluid abilities declines. So what's crystallized abilities? Well, crystallized abilities or crystallized intelligence is our knowledge, our fact base, our semantic knowledge. And your crystallized intelligence by the end of today, I arguably got a little more crystallized because many of you are learning new things. And so I've added more facts to your world. And over time, we learn more facts. In contrast, fluid abilities describes our ability to multitask, apply a decision rule in the face of new information to make a decision. It's important for learning a new skill. It's important for making a decision with new information. And as you can see, it declines over time. But the other thing you can see, and why I picked these graphs, is tremendous variability. So each of those dots is a human, and I hope you can see that as a group, older adults are showing a decline in fluid intelligence. But some of them, even in their late 80s, 90s, are doing as well as the younger group. But some of them in their late 80s and 90s are doing quite poorly. So you can't make a summary judgment. Oh, you're 80, you have declines in your fluid abilities. But the pretest probability that you do is greater. Now, the clinical, again, this is from data that if they show up at the memory center, I'll say, you're fine. You have some subjective complaints about cognition, but I don't pick up any evidence of either MCI or dementia, and therefore no further workup to figure out if there's a disease causing the MCI or dementia. Could we someday say that declines in fluid abilities are a disease state worthy of a diagnostic label? Well, that's another conversation another time, but we know, we have data that declines in fluid abilities can impact on your ability to do higher level IADLs, instrumental activities of daily living, like managing your money. And so this is, for example, one reason why older adults are particularly vulnerable to fraud, scam, or their own mistakes with managing their money. And just to leap ahead, it's all very well to make a bad financial decision at 30, 40, 50, 60 maybe, because you can come back, recover it, keep on working. But it's harder to do it when you're 70, 75, or 80 to re-enter the workforce if you've made a mistake. And that's when you need the money. So aging is associated with changes in cognition, either because of diseases, and the most common is Alzheimer's, but there are other diseases, I mentioned already, Parkinson's, Lewy body disease, and the hallmark across all of these neurodegenerative diseases is that neurons are dying. So if I look, for example, at an MRI of the brain of an individual with dementia or MCI caused by Alzheimer's, I'll often see less brain tissue in certain regions than I would expect, showing me one of the effects of the effect of dead neurons, dying neurons. In contrast, with aging, we see changes in neuron function, particularly in the prefrontal and frontal regions, which cause these declines in fluid intelligence. Neurons don't work as well. And just to hammer cognitive aging home, it's not just an artifact of our measurement. It's not just something that is a product of our culture. We can verify and validate cognitive aging in other non-human primates, such as in non-human primate models or in animal models like dogs, etc. In fact, one of the biggest areas of research in cognitive aging in terms of interventions and study is in service dogs, because the amount of money and effort spent to train a service dog to go be at the Amtrak station and sniff the baggage and whatnot is tremendous. And unfortunately what happens is those dogs age and are frankly less good at that work. And so there's a tremendous effort by Department of Defense and others to try and identify and mitigate the effects of cognitive aging on dogs. And the point I've already gestured to is that changes in cognition can lead to losses in the ability to perform tasks and make decisions. And here's one example of that from a paper that looked at a large data set of adults from the ages of 18 to 65 and their performance of a variety of different financial tasks. And this is just one financial task, which is the eureka moment when you realize that the credit card you're using to pay down your credit card debt from another credit card actually is charging a rapacious interest rate when you use it to purchase. And the eureka moment is when you say, I should just use that new credit card to pay the debt down and the old card to make my purchases. And people figure that out more, some do, some don't. This U-shaped curve is showing the proportion of people that figure that out. Now on your left-hand side are the young folks. They don't really know much. They just left their parents' basements and kind of figure out where things are. But over time they learn and also gain more fluid intelligence. And so, but then you see around 50 or so, there's a drop. And the belief is that that drop likely reflects these changes in fluid intelligence, despite increasing crystallized intelligence. And this is just one graph of multiple different financial decisions these individuals looked at that show the same U-shaped behavior, the same U-shaped behavior. And this is gesturing to the fact that for someone like me, boy, I'd really like to see those data with respect to my patients, okay? This is as valuable to me as the history that I'm getting from their family member. In fact, arguably, I don't want to say it's more, but this is great data, not just to do research, but to identify people who are having problems. Now, this is a legal financial transaction that, whatever, but imagine that these were bad transactions, fraudulent transactions, excessive. I saw a patient 2 weeks ago whose wife finally discovered when she looked at his Quicken account that he had dragged himself about several $100,000 into debt with purchases that just were not making any more sense. She had finally had the opportunity to look at his Quicken account. All of that could have been detected ahead of time. There was no excuse for that. I've had patients come in $900,000 out of $1 million of retirement savings because they got hooked up into an international lottery scam. All that was going on, all that was being watched. I mean, like a hemoglobin A1C rising that no one ever just went to the lab, drew this test and showed, oh my God, the guy's got a hemoglobin A1C of 11 or blood pressure of 180. Pick your metaphor. This is real. This is my patient, Arthur Packle. He sadly died a few years ago. Behind him is his wife, Renee. I can say their names freely and openly because they were on the front page of the New York Times reporting on how money woes can be an early clue to Alzheimer's. When I saw Arthur Packle and diagnosed him with Alzheimer's, he had a mini-mental of 27, which would be normal by standard norms. But with a more careful history and exam, I clearly picked up that this gentleman who was having cognitive decline, and the cause was Alzheimer's, and ultimately a brain autopsy would prove that some 13 years later. His chief complaint was not his chief complaint. He thought everything was fine. His chief complaint was his wife, Renee, who you see standing behind him, who brought him in to me because she had gotten a call from their homeowners association that he hadn't paid the homeowners association bills in 3 months. She looked closer, and not only had he not paid the bills, he had made a series of transactions with respect to his reinsurance business that he ran that cost him their business, and therefore cost them their home, and ultimately a settlement where I had to fill out a variety of forms to say this, to get some forgiveness for them. They sold their home, they sold their car, they moved to an apartment in the city, and she, for the first time in her life, went to work, and still works today, actually, interestingly. And the rest is history. All of that could have been picked up. All of that could have been detected had we identified earlier with Arthur, Mr. Packle, excuse me, that he was having problems. And his story is not unique. As Gina Collada's headline is, money woes can be an early clue to Alzheimer's. And it only makes sense when you think about it because financial transactions are among the more cognitively demanding, fluid intelligence intensive activities that people have to do. And again, this graph, now back to data, if you will, moving away from anecdote, just reiterates why I have to talk to Renee Packle, why I have to talk to an informant at the Memory Center, why we have to convince a health system to buy not just 2, but 3 chairs, one for me, one for the patient, one for the family member for the exam rooms. Complicated graph, but actually fairly simple. That's 24 months of time on the x-axis, 2 years. People followed every 6 months, filling out as just a straightforward Lawton-Brody IADL form, ability to manage money, medications, transportation, telephone, cooking. And higher scores, greater function, lower scores, you've lost function. Ask a patient with Alzheimer's disease, the black dot, to fill out the IADL form, fairly static, not a lot of change, things are going pretty well. My memory's not as good as it used to be, but basically I'm doing all right. Ask Renee Packle to fill out the same form. Right there at baseline, you see that gap, that's the diagnostic gap. She says, no, there are some troubles. And of course, sadly, what happens over time is the relentless decline of loss of function seen in dementia. Just that you don't think this is an artifact of spouses disagreeing as they always will, or adult children seeing their parents as hopelessly inept as they always do. The upper lines, the 2 boxes, are a comparison group of cognitively normal older adults and an informant, and you see no difference until later, as some of those cognitively normal older adults are actually developing impairment, which is wonderful after 2 years of follow-up, you see that. So that's why you need to talk to someone else. And that's why I still have to do what Dr. Alzheimer's did, which is talk to someone else in my clinic. And that's why I wonder, why can't I also get an alert from an aggregated set of their financial transactions to let me know that indeed there have been some problems here. This guy has been racing up credit card bills totally out of character to past behavior. Totally out of character. In the United States, we think there are about 5 million people with Alzheimer's, depends on how you define it to make that estimate, and that number is in the setting of having no effective treatment. I cannot prescribe a drug that I can say with confidence, like I could prescribe if I was an oncologist, a drug that I could say will go after the actual biology of the cancer. I don't have that available. But I will say, and here's encouraging news, which is over the last 30 years, multiple studies have been showing that the risk of developing dementia has been declining. It's not an artifact of one study. Multiple studies in industrialized nations following people for time have shown that the rates of dementia are not as increasing at the rates we saw, the incidence, the risk. There's still plenty of people with dementia. There will be plenty more. So something's going on already. And we think from those cohort studies that it's access to health care, particularly cardiovascular care, thank you Medicare. It's access to education, social and economic stability. So there are things that we're already doing which tie back into things that we can do now to better create social and economic stability for our older adults. Depending on what models you use, you can get a wide range of what the cost is, but whatever model you use, you come up in the billions for the cost of the disease. And my key point here is that the majority of the cost of Alzheimer's disease, of dementia in America, is the cost of long-term care. Not necessarily institutional care, but just someone having to watch over, take care of, and look after someone. And if you monetize the time of caregiving, it translates into this billions of dollar cost. Meaning, when that patient I told you who lost 9/10 of her nest egg lost that nest egg, I remember her son, who is an accomplished professional, fortunately, I guess, because he called me up and said, well, now I'm going to have to pay for all this for my mom. I can do it, but, you know, imagine if he wasn't an accomplished physician, which he is, and therefore could just dip in. But that's money that he doesn't have now to do other things. I've mentioned fraud and abuse, and I think the numbers that are out there are just guesses. I have no idea really what a good number is to estimate the costs of fraud and abuse, the stealing that goes on. I will say this, even though no one really has a good number, every time you get a room like this, put a sign out front and say, we're going to have a conference, a talk on fraud and abuse of older adults. And I invite various banks and institutions, they all show up. All the leading financial institutions show up. And they're not showing up because they don't know about it. They're showing up because they know about it. They just don't share the numbers as transparently as I think they could and whatnot. But that's a story for another time. Okay, let me show you some data from the Chicago Health and Aging Project. People followed older adults, well-characterized cognitive abilities, followed every year, ultimately when they die, then getting a brain autopsy. Excuse me, the Memory and Aging Project. This is a separate study. And I just want to show you some quick data. They added some measures into their annual assessment of financial literacy and decision making, and then sought to look at how does performance on these measures of financial literacy predict later development of dementia. How does performance on these measures of financial decision making predict the development of later dementia? And I won't go granular into their data in the interest of time, but to get to these two graphs, which is the measures of financial literacy in cognitively normal older adults predicted down the road, you can see here 5 years of time, the likelihood of developing later being diagnosed with Alzheimer's dementia. Then the measures of financial literacy, let's not get too enamored of our objects of our measurement, were questions about, you know, if you have $1,000 and the interest rate on in your savings account, the interest rate is 10%, well, that's absurd, but, you know, how much money in 1 year would be in your account. So they're just math problems, and let's not be too enamored of them. But what they're trying to get at is in these cognitively normal older adults asked to make simulated decisions about managing money or simulated decisions about how to manage money, you find that performance when they were normal that was low predicted later development of problems. So again, they're out there in the world doing things, and that's data, if you will, that's presaging that there will be problems. Very important in a country that wants to prevent this disease by 2025 from a public health perspective of surveillance, which is one of the, so if you're going to prevent, you need to surveil. And this is the same result shown around the decision the measures that they used around financial decisions, choosing the right plan, for example, for an annuity. So financial literacy and decision making from this study of a cohort of individuals in the city of Chicago do decline with advancing age, and they are predictive of impending cognitive impairment, developing dementia level impairment. My field is enamored of biomarkers, PET scans, MRIs, and spinal fluid measures of the disease. And we should be, because they provide a target for drugs. But these are effectively biomarkers as well. But they're real-world biomarkers that have real-world implications here and now. So what I want to do is just review a bit of the data around the implication of aging, cognition, and financial well-being. So this graph here shows the is a study done by the National Health and NHATS, which is a cohort study done in the United States. And here is reporting that in individuals who have established dementia, those who need assistance with instrumental activities of daily living. And no surprise, the majority of them need help in at least one IADL. IADL meaning managing money, medications, telephone, transportation. And this typically involves needing help with finances. It's the toughest IADL to do, and if you make a mistake, quite costly, quite literally. And all this is trying to show here is that children typically are replacing spouses in this role as individuals develop cognitive impairment. And I'm just jumping here, mindful of that. This is an adjusted model here that simply shows that even after you control for characteristics of the individual, if you have someone helping you with your finances, you're less likely to have problems managing your finances. So it isn't just an artifact of your cognitive impairment or an artifact of other social or demographic characteristics of the individual, but having someone helping you with your finances decreases the amount of problems you have with it. Sort of obvious, okay? But of course, having someone helping you with your finances is, of course, a setup for having someone defraud you of your finances. And the majority of cases of fraud and abuse are done actually by caregivers, by family members. We could debate, some would argue, well, I didn't think I was defrauding my mother because you don't know what it's like to take care of her and how amount of money I'm losing from my employment, so that's why I was. We could debate whether that's right or wrong. It, I think, reflects some of the larger problems with how we provide long-term care in America. But the majority of fraud and abuse is caused by someone else helping someone, typically a family member or friend or neighbor. So most individuals with dementia need help managing their finances. If they do, it lessens the amount of hardship they have. And if they don't have someone helping them, they have even worse financial hardship. So now what I want to do is just look at the general financial landscape for aging Americans. These data are just about older adults, not specific to them having dementia or not having dementia. And the point I want to make with these slides is that aging Americans, to paraphrase Patrick Harker, the president of the Philadelphia Federal Reserve, excuse me, there's a bit of a bubble here. And when someone from the Feds uses the word bubble, you better pay attention. So the first is the changing nature of the money we have, the kind of money we have when we retire. And it's this shift from a defined benefit plan to a pot of money. What do I mean by that? Well, I'll show you what the shift is. So in the red there is what we call defined contribution. That's an IRA, a 401, that kind of thing. And the blue is the pension, defined benefit. And the green is people who have both. So the pension's what sort of, that's the check that comes every month after you retire, just like your paycheck came, managed by someone else, guaranteed, okay? Outside of Medicare, those are fading. What is increasing is reach your retirement age and you're handed a pot of money. Here you are, here's your 401k, go to it. It's yours to manage, or yours to be fleeced, or stolen, or make mistakes on. And so this hammers home the importance of looking after the financial health and health of older adults, because they're being handed these pot of money, and that's what they need to take care of themselves as they age. And remember, they've retired. They're not able to easily just flip back into the workforce and recover any of the money that they lose. So this is a steady, ongoing trend. What about the debt that older Americans hold? The data are concerning, and here you see these colors now are age groups. So we have 1992, 2001, 2007, 2016 epochs. And the blue is all older adults, and then red, green, purple is age categories 50 to 64, 65 to 74, 75 plus. And I think what you can see is a general rise in percentages of American families with heads who are 55 and older who have debt. What's most concerning is the 75-plus-year-olds holding more and more debt. The data suggests, EBRI, chatting with them, that so much as the student loan debt that grandparents, because who doesn't love their grandchildren, have taken on in order to educate their children, their grandchildren. So rising debt. So pot of money, rising debt. This is just looking more granularly about the median total debt. You see that rising, and I believe, yeah, I didn't. And this simply shows that the amount of debt is rising, the dollar value, the median dollar value is rising, particularly in the 75-plus-year-olds. And then finally, the impact of long-term care. Remember, the majority of costs of Alzheimer's, of dementia in America, agnostic to cause actually, Alzheimer's or say Lewy body disease or Parkinson's, is the need for long-term care. That's the biggest monetary cost right now. The time spent supervising, looking after, whatever. You know, Mrs. Packle made that lunch for Arthur that you saw him eating in that photograph, and she had to take time out of work to come home and do that. That's what she got a job close to their apartment. So this is a simulation model that the EBRI ran. So early baby boomers and Generation X, two different groups of people. And this is a simulation model, which is what's the impact of needing long-term care given retirement readiness of those two cohorts. So the blue is if you run a simulation models where the person doesn't need long-term care. So the expenses they're going to have are things like just paying for food and housing and other things. But the red then is if you add the expense of long-term care. And I think you can see a stark drop here in people having enough funds to provide for their long-term care. And it doesn't get any better then, obviously, if you have cognitive impairment. So back to Arthur and Renee Packle. There was no reason why, when you think about it, we have to wait for her to notice the problems because the homeowner association calls, and then she starts looking and finds everything there could have been found. The patient I saw a few weeks ago where Quicken was what she looked at. I mean, she could have been alerted, you know. There's no reason when you think about how electronically aggregated and collected financial information is that we can't think about ways to learn and therefore discover trends of people who are having emerging cognitive problems and or being defrauded because they're having cognitive problems, whether that's because of cognitive aging or because of disease. So I talked about how cognition changes over time with age. I hope I've emphasized to you it's not just Alzheimer's. There are other diseases, number one. But it's not just disease. It is real, namely cognitive aging, and the effects on fluid intelligence, fluid intelligence are real, and for higher level IADLs can cause people to make mistakes and be defrauded. The earliest signs often of cognitive impairment and or cognitive aging can be difficulties with financial decisions. The economic impact I hope I showed you is large, both for the individual as well as their families. And we are in a situation in this country because of decisions we made around how to structure retirement that we are handing older adults pots of money, if they even got a pot of money. Many don't have a 401k, et cetera. They've got very little at best. And letting them go off on their own with that to take care of and pay for things for themselves and for their families. In the setting of rising debt, and in this country we've decided that Americans will bear the majority of the costs of long-term care, unless you're, of course, poor enough through Medicaid, et cetera, to have that. So those are my overall points. I have this website we've created, wealthcare.org. You're welcome to go visit it to learn more about everything I've talked about here and more. There's a more detailed reporting, for example, on the event that we had at the Philadelphia Federal Reserve. And so next up, I assume one of you will be introducing Simeon Niles. Okay. Thank you very much.
Thank you very much, Jason. That was wonderful. Our next presenter is Simeon Niles. Simeon joined the Division of Population Health Incentives and Infrastructure in the Prevention and Population Health Group at CMMI in December of 2014. So that means that we've known each other almost as long as you've been at CMMI. So you get like the great red star because that's exactly the way that we're supposed to be working together. Prior to joining CMMI, Simeon was a federal healthcare consultant where he provided legal, analytic, and project management support to clients by monitoring the development of federal and state legislation and regulations, and supporting process improvement activities, including workflow enhancement and agency clearances. He received his JD and his MPH from Emory University and his bachelor's from Hunter College. Please join me in welcoming Simeon.
There's the screen up here. Good. Good morning, and thank you, Karen, for the invitation. I appreciate the opportunity to come and speak to you about the Accountable Health Communities model. First, I'd like to just take a little segue because there was a chart, Dr. Karlawish, that you had displayed your first graph up there that showed like the eureka moments for different age groups, and that's totally resonated with me because as I saw, like I have conversations with my nieces, they're 16 to 19, and every time I try to have like a conversation with them, they look at me as an old guy, and they talk like, they always talk like they're in constant pain, and so it's just like, oh, Uncle Simeon, you don't know what it's like to be me. Like, I only got 100 likes on my picture. And I'm just like, are you serious? Like, this is sort of like the issue of the day. And then in terms of like, I think George Hoffman discussed the amount of data that we share in this new age, and seeing that, they take the picture, they turn on the location for the picture. In the comment section, it's a running dialogue with their friends about what they're doing constantly. And I just think back, like these are conversations that at one point, at least in my day, I had face to face with someone, or I had a text message conversation that now is on display for the world to see, and for data to be collected about them individually, about what they like and don't like, et cetera. And then on the far end of that, and I think this conversation is very timely, is about sort of how my parents are accessing their data and making financial decisions. And currently I'm going through that issue with my mom, who's in her 60s, and anyone that has a West Indian mom knows that it's challenging as a child, and she still considers me a child, to have conversations about managing her finances, because I'm always constantly told, like, I raised 5 kids on nothing. When you do that, then you can come and tell me how to manage my finances. And so, having to balance those conversations and say, okay, I won't tell you how to manage your finances, but I can give you more information and help you appreciate sort of the pros and cons and the costs of the decisions that you make. And that seems to be working, at least for now. So that eureka moment also gave me a eureka moment, and at least let me know there's data to support the way that my nieces and my mom interacts with me. So, as I think Karen had said before, my name is Simeon Niles. I'm the program lead for the Accountable Health Communities model in the Division of Population Health and Health Incentives and Infrastructure in the Prevention and Population Health Group at the Innovation Center. And today I'm here before you to share with you the 4 ways that we collect, use, and share data to address patients' health-related social needs. Do I press up here? Okay. You said press the green button. So many of the largest drivers of healthcare costs fall outside of the clinical environment. I think there's, that wonderful pie chart that shows like 40% of the drivers of health are around social and economic determinants, 20 to 30 around health behaviors, physical environment, and then another 20 or 30 around clinical care. And then there's emerging evidence that by addressing health-related social needs through enhanced clinical and community linkages, that you can improve the patient's health and improve health outcomes and impact total cost of care. And so the Accountable Health Communities model was developed to address the current gap between the healthcare delivery system and community services. So the Accountable Health Communities model is a 5-year model test that tests whether systematically identifying and addressing the health-related social needs of community-dwelling Medicare and Medicaid beneficiaries impacts healthcare utilization, quality, and costs. And so it's a 5-year model test that targets specifically Medicare and Medicaid beneficiaries, including those who are dually eligible, and it's a 2-track model, meaning that there are 2 different interventions that are implemented in the model. When we talk about health-related social needs, we're talking specifically about those non-medical factors that drive healthcare utilization and cost. And within the model, those are divided into 2 categories. They're core health-related social needs, and in the context of the model, that's housing instability, utility needs, food insecurity, interpersonal violence and safety, and transportation. And they're core health-related social needs and are thus required to be screened for and addressed within the model by everyone participating. But we also allow for some local determination, recognizing that each community is unique, and so we allow for the screening and addressing of supplemental health-related social needs. And I think the ones that are most germane to the conversation today are family and social supports, financial strain, disabilities, and mental health. So in April of 2017, last year, we awarded 32 cooperative agreements to communities across the U.S. These are communities that are to encourage a community of partners to form, which would be led by a bridge organization. And the bridge organization serves as the lead fiscal agent for the cooperative agreement. And their responsibility is to pull together community stakeholders into an accountable community to address health-related social needs. The key partners in the Accountable Health Community is the state Medicaid agency, whose primary responsibility is to ensure alignment with Medicaid policy at the state and local level, as well as to ensure that the services are delivered in a way that is not duplicative and that payments are not duplicative. Second partners in the community are the community service providers. These are the organizations, community-based organizations that have the capacity and ability to address at least the core health-related social needs. But if, again, an organization chooses to screen and address the supplemental needs, then they should include those partners as well. And the third set of stakeholders, partners, are clinical delivery sites. We, at a minimum, require the participation of a hospital, a primary care practice, and a behavioral health treatment facility. But there are also other practitioners and providers that are encouraged to provide care and participate in the model. As I stated before, we have awarded 32 cooperative agreements to various communities across the U.S. That covers or spans 24 states. You see there's 6 in the Northeast, 7 in the Midwest, 8 in the West, and 11 in the South. And they really represent, so we really were able to award a geographically diverse set of communities. They represent both urban and rural communities. And here's a list of those of the awardees, and you probably can't read that, but I just want to call your attention to 2 of them in particular. As you can see, there are many sort of hospitals, health plans, and primary care practices or associations that are participating, but I want to call your attention to the United Way of Greater Cleveland. They are one of our awardees, as well as a local public health department, Baltimore City Health Department. Currently, the awardees are working to establish processes for delivering the interventions. They're currently in their startup period, and implementation, that is screening and referral and other interventions, are expected to begin between May of this year and August. Now I'll discuss the interventions and the 4 ways in which we use and share data to address patients' health-related social needs. And so the first way that we use data to address health-related social needs is by charging our bridge organization with the responsibility to develop a community resource inventory. This is an inventory repository of all the resources within the community that may be able to address the health-related social needs that are identified. And so they have to work very closely, particularly with the community service providers, in order to understand what their capacity is, to understand specifically within the domains that are listed, those 5 domains, housing, food insecurity, et cetera, what's their capacity and ability to address those particular domains and exactly how they address those domains. The second way that we use data to, I'll go back. Can I go back? All right. Second way that we use data to address health-related social needs is through the primary intervention in the model. And so that intervention is screening and referral for health-related social needs. The way that beneficiaries enter the model is that they go to their doctor's office or the hospital, and that they're screened using the Accountable Health Communities Model Health-Related Social Needs Screening Tool. We like long names here. And so our team here at CMS at the Innovation Center developed this tool. We convened a TEP that selected a series of screening items from various validated instruments. Where there were no validated instruments or agreed upon validated instruments, those group of experts came together to formulate particular questions that they believed would be useful in identifying those social needs. We had our contractor pilot test the tool for usability and readability. And so when you see those core health-related social needs, that resulted in a 10-item screening instrument that I think in pilot testing, we determined it took a little bit, between like 7 and 10 minutes to administer, to self-administer, and maybe took a little bit longer, maybe an additional 2 minutes if it's facilitated. But the beneficiary enters those clinical delivery sites, their doctor's office, the ER. They're met by a screener who offers them the ability, the opportunity to participate in the model. And thank you again to Karen and her team, because we've been working diligently in crafting the Privacy Act notice statement that will accompany that screening tool. That allows them to know that the government will be accessing and using their data for the purposes of the model. And so they are met and offered the screening instrument, they complete it, and then they take the results of that instrument and then marry it with the community resource inventory that's been developed. Again, that's the inventory of all the resources within the community, and that allows the provider and the screener and the provider and the patient to understand what the needs of that beneficiary are and then map them to the resources in the community that are available to address those needs. Some of the ways that folks are using the screening tool, as I said before, we are in the startup period, so we actually haven't begun seeing beneficiaries yet, but we do know based on what they have told us as project officers is that they plan on administering the tool mostly in the electronic format. So they're using iPads. Some of them are going to use mobile phones because not sure why, but they're using iPads, and some will also do paper referrals. There will be some facilitated screening, so someone sits in front of a screener and the screener reads the questions and enters it into a terminal. But I think the unique aspect of the model is that they're thinking about various ways about implementing the model using technology. We do at least have one organization community that's looking to integrate it into their EMR, so that because they have a large physician practice group that wants to have it integrated into their portal, so that the beneficiary can fill it out before they come into the doctor's office. And again, that allows the physician a little bit more time to understand, in addition to why you're actually coming to see me, those medical needs that you need addressed, they also have a fuller picture of the beneficiary and their social needs. As I stated earlier, there are 2 tracks to the model, the assistance track and the alignment track. In the assistance track, we awarded 12 communities, and the primary, in addition to screening and referral for health-related social needs, There's also navigation services that are provided. And by navigation services, I mean case management services specifically targeted towards addressing those social needs. And the case management services means that a navigator, after a beneficiary has been screened, they've received the referral, their needs have been identified, they've now been equipped with a referral to go out and try to solve some of their problems. They've been empowered in a sense. But we recognize that there are some beneficiaries, again, high-risk beneficiaries that may need a little extra help. And so that's when a navigator follows up with those beneficiaries to help them access these services. And so the data that the navigator has is the results of the screening instrument. So they know what needs are identified and they know what resources have already been shared with the beneficiary. And so what that navigator does now is they have a conversation, we call it a personal interview, with the beneficiary to really drill down to understand sort of the root causes for these needs, and also to confirm that the results from the screening tool are actually present, and to also identify any additional needs that maybe were not missed by the screening instrument. For example, one of the core health-related social needs are interpersonal violence, but we do recognize that's an extremely sensitive question to respond to, depending on if you can even respond to such a question in that given moment. But through follow-up with a navigator, we expect that they may be following up for the appearance of a food need, but they may be able to understand if there's another need, such as an unsafe environment that beneficiary lives in. And so this is also marks sort of the third point where data is collected about the beneficiary. It's through the personal interview that the navigator, again, understands the beneficiary's the root causes of the needs for the beneficiary, and then they work with that beneficiary to develop an action plan. And that's sort of the targeted plan about how they together are going to address this beneficiary's needs. And that may mean that the beneficiary needs reminders that, hey, you should follow up with a particular community service provider. That may mean that the navigator calls the community service provider to set up appointments for them, et cetera. Whatever is established under that action plan in partnership, that's developed in partnership with each other, that's what's enacted, and that serves as that third use of data to address the beneficiary's needs. The second track in the model is the alignment track, and we awarded 20 communities in the alignment track. And so the alignment track also provides navigation services, again, to those high-risk beneficiaries, but it takes that individual level intervention and couples it with a community level intervention, whereby that bridge organization is charged with pulling together all those community partners. Again, those are the clinical delivery sites, those are the community service providers, that's the state Medicaid agency, to form an advisory board. And the role of that advisory board is twofold. One, it is to take the data that's thus been generated and understand where there are gaps for addressing needs. So they're taking that real-time data about all of the beneficiaries' social needs, and they're taking real-time data from navigation because the navigators are also responsible for identifying whether those social needs have been resolved, and then they're understanding within that particular population how the community is meeting the needs that have been addressed and whether they're meeting those needs. And again, that marks sort of the third use of data. It's the navigation data coupled with the screening data that empowers and allows that advisory board to understand what's going on in their own communities. They're also able to use secondary data to support some of that work, and they use all of that data to develop a quality improvement plan. And that plan, again, is the community strategy for figuring out how to meet the needs that are being addressed, and also how to meet those needs, and also how to streamline the delivery of services so that they are targeted to the people that need the most in the most efficient way possible. Just to also speak a bit more about that, that data isn't given to them wholesale. I know we talk about the data privacy here, and that's sort of it's a data privacy day. It is aggregate data that's provided to that advisory board, and all the beneficiaries that participate in the model are selecting to participate in the model and are made aware that their data is being used by CMS for the purposes of that model. So targeted outcomes from the model are increased beneficiary as well as provider awareness of community resources, increased beneficiary access to community resources through navigation, optimize community capacity to address health-related social needs through implementation and evaluation of the community's quality improvement plan, and reduce inpatient and outpatient healthcare utilization and costs. Performance metrics include healthcare utilization, so that's our emergency department visits, inpatient admissions and readmissions, as well as outpatient services, total cost of care, and provider and beneficiary experiences. And so key innovations in the model are systematic and universal screening of all Medicare and Medicaid beneficiaries to identify their unmet health-related social needs, testing the effectiveness of referrals and community services, navigation on total cost of care using a rigorous mixed method evaluative approach, as well as partner alignment at the community level and implementation of a community-wide quality improvement approach to address beneficiaries' health-related social needs. Also, just capping it all off, 4 ways we use data: development of a community resource inventory, screening and referral for health-related social needs, the action plan that's developed using that screening information, and we use aggregate data the community uses aggregate data to develop a gap analysis and a quality improvement plan to, again, increase and optimize the use of community services to address beneficiary social needs. Thank you again for the opportunity to come before you and talk a little bit about the Accountable Health Communities model. If you'd like more information, please check out our website. We do have our screening tool on the website, as well as a paper that describes how it was developed. And if you have specific questions that are not answered by the website, feel free to email us at our inbox, which is above. Thank you.
Thank you so much, Simeon. I think we have time for questions now, right? No questions. Well, if anybody does have questions, they should please feel free to ask them. But I think we're going to take a break then for a few minutes. So we're going to reconvene at 10:45. Thank you. Are those on? Oh, here we go. Okay, great. Okay. Could everyone come join us again? We're gonna, and can I ask the presenters, Sandy and Lauren and Larry, to come and take the seats up at the front? So I'm going to take this opportunity to talk a little bit. I'm just going to take a couple of minutes. So one of the most profound things that I learned when I went to Philadelphia to the Federal Reserve in November was that of the people, and this was in one of the slides that Dr. Karlawish showed, of the people that actually have the means to save for their retirement, because of the advancements in treatment and therapy that researchers like Dr. Karlawish are making for conditions like Alzheimer's disease, more than 50% of those who would have died before they had used up their retirement resources will soon outlive their retirement funds. What will this mean for the dual eligible population? Who will be the caregivers for this next generation, where the birth rate is flat and even dipping into being and projected possibly to being negative, and probably most significant, how will we pay for it when the number of people paying into our programs here at CMS are becoming smaller than the number of people that need those services? So before I introduce the people that are sitting on the panel this morning, I'd like to tell you a personal story about where I began to learn to appreciate the value of having full visibility of a situation and what it means for a physician to be able to treat the whole patient. One of the most special memories I have from my childhood were Sundays that I spent with my father. He was a doctor, and if I woke up early enough on Sunday mornings, he would take me with him to the hospital to make rounds. Sometimes we would stop at the nursing home too, and then there were a few patients that he would even visit at home. Yes, he would make house calls. It was a different era in healthcare, so work with me. I'd go with him to the hospital room, and he'd introduce me to his patient. He'd sit with his patient, and he'd talk to them about their family. They'd talk about something that interested the patient, and eventually they'd draw me into the conversation too. Something like, Karen, this is Mr. Johnson. He's an avid fisherman. He even makes his own fishing lures. And he'd get Mr. Johnson to tell me something about fishing and the lures that he designed. Or, Karen, I want to introduce you to Mrs. Dunn. She's a really special person. Mr. Dunn's mother was a scrub nurse at the University of Minnesota when I was a resident. She scrubbed in with Dr. Varco, one of the first surgeons who performed open heart surgery in the United States. And she actually helped me do my thymus gland research. Or he'd tell me about Mrs. Miller, about her talents as a seamstress. And he'd remind me that the Barbie dolls that we played with were dressed in the clothes that she had sewn by hand. He not only knew his patients' conditions, but he also knew them as people. He would sit calmly and chat with them and calm them. And he paid attention to things other than just the diseases that they had. He talked to them about, sometimes he would give his patients, sit with his patients when they would be getting chemotherapy. And he would tell me that the reason that he would do that was because he wanted to make sure that they were thinking clearly. He'd watch them and he'd talk to them. And he always relied on my mother to make sure that there was a pot of chicken soup in case he had a patient who couldn't eat solids and needed clear broth. Depending on how many patients he had in the hospital, rounds usually took up to 5 hours on those Sundays. And then we'd go home and he'd make pancakes, and while he made pancakes, he would give me an index card. And he'd have me draw vertical lines across that index card, and then he'd tell me the names of his 10 sickest patients. And I'd fill in those names. And he made sure that 3 times a day, his 10 sickest patients, that he had their vitals. And he understood what was happening to them 3 times every single day. I still today sometimes think of those index cards as the precursor of what we call electronic medical records, only he kept it in his shirt pocket, and it actually worked. What my father had taught me was that you can't really treat a patient effectively just knowing the patient's diagnosis without having an idea of some of the other things going on in that person's life. He knew who was helping to take care of the patient. He paid attention to what his patients ate. He knew if they had enough money for their medications. He worried about whether they remembered to take their medications. Did they have a comfortable place to sleep and rest? He worried about whether they had a way to get to and from the doctor, and that's why sometimes he would go to their homes. So last May, I got an email, and the subject line read, "Help for the Federal Reserve Bank." For those of you who didn't know Bo Hauser, he used to be the Deputy Chief Information Security Officer here, and if it wasn't about networks or cyber threats, or some system security thing, he would just forward the email to me. For a moment, I thought, really? The Federal Reserve Bank needs my help? You gotta be kidding me. But I opened up the email, and it had come from our regional office in Philadelphia. And they were asking about data sharing, HIPAA, cognitive dysfunction, financial transactions, suspected fraud, using financial information, medical information, all in a data hub. So it really was up my alley. And within a few weeks, we scheduled a call with Larry, who's one of our presenters today, whose brainchild this all is, to talk about Larry's research. He shared his paper, and I was immediately intrigued. I'm just going to take a second to say that I said this about Larry in Philadelphia. Larry's done an amazing thing. Sometimes this is something that few people will ever do in their lifetime. He got a bunch of really smart people from two very different industries that usually don't communicate with each other into a room, and we talked for almost 2 days. And at the end, the consensus was that this is really an important topic, that we want to continue meeting and learning more, and hopefully one day we'll come up with a solution. One of the most poignant examples of this was brought to life when we were in Philadelphia. We had the honor of meeting Philip Marshall. His grandmother was Brooke Astor. The short story is that Philip brought his own father to justice for elder abuse of his grandmother. One of the legacies of that case was that the attorney from the prosecutor's office who tried the case, Elizabeth Lowy, started an organization called EverSafe, the first technology-based solution designed to recognize various forms of financial abuse that plague the elderly. And her co-founder, Howard Tischler, is here with us in the audience today. But during that first call, I thought about Simeon and the Accountable Healthcare Communities model that our Center for Medicare and Medicaid Innovation is launching. Another very gifted and insightful person. When people talked about patient-centered healthcare, I had always envisioned a wheel with a hub and spokes, with the patient in the hub or the center, and at the end of each spoke, there was someone else who contributes to the well-being of the patient. I also thought on that phone call about my colleague Sandra Raup, who has been an advocate of patient-centered healthcare for decades. But the permissions for sharing under HIPAA focus on covered entities, the providers and the plans, sharing information about their patients and beneficiaries, and not putting the patient in control, a paradigm that's actually now beginning to shift. Simeon and Larry challenged me to think that people at the other end, that people other than healthcare providers might be at the end of one of those spokes. Could a financial planner or a legal advisor or an EverSafe be one of the services that a patient might need to save them from doing something that would cost them dearly? And then I realized that was what I had experienced watching my father orchestrate care for patients. Our panel today is going to talk about a type of IT platform or solution that can be leveraged to support the network of people that it can take to take care of someone with any chronic illness, even an illness like Alzheimer's, and what the challenges and barriers to sharing information are that need to be overcome for two industries, the healthcare industry and the financial services and banking industry, where trust relationships are key so that people can plan appropriately get the care and treatment they need, and the aging process, as they age, and making the aging process a little less stressful and risky. What has become clear to me is that when people have either a brush with some financial exploit or healthcare event, they want to share their experience so that others don't fall prey to the same or same thing, or that they can also otherwise benefit. So join me in welcoming our panelists. Our first panelist is Sandra Raup. She started her career as a clinical dietitian working with some of the pioneer multidisciplinary nutrition support teams in Minnesota. She's a graduate of the University of Minnesota in nutrition and dietetics, and she later graduated from the George Washington University with degrees in law and public health. She also has experience in primary care quality and coordination. She's now the president of Daytuit, which is her second healthcare information technology startup. Sandy has a deep healthcare background and understands the challenges that face patients and providers alike. She has developed, implemented, and supervised innovative programs and protocols throughout her career and is now focused on bringing new technologies to the healthcare delivery system. She works with others to create ways for clinicians, patients, and caregivers to collaborate. Our second presenter on our panel is Larry Santucci. He's a senior industry specialist at the Federal Reserve Bank in Philadelphia in the Consumer Finance Institute. Before joining the bank in 2013, Larry spent 8 years in consumer lending with a focus on data, analytics, and business strategy. His consumer lending experience includes small dollar and unsecured installment loans, credit cards, and residential mortgages. He has also worked as a research assistant at the Federal Reserve Bank of Richmond. He holds a master's degree in economics from Pennsylvania State University and a bachelor's degree in economics and business administration from Ursinus College. And third, Laura Hirsch-Nicholas is an assistant professor of health policy and management at Johns Hopkins Bloomberg School of Public Health. She's a health economist whose research focuses on the role of public policy in improving health and healthcare quality for the elderly. Her current research combines survey, administrative, and clinical data to study the interaction between healthcare utilization and economic outcomes. Lauren's work uses clinical and econometric approaches to answer questions in medical and health economics, particularly for surgery, dementia, and end-of-life care. She has received several awards for her research, including the National Academy of Social Insurance Johns Hines Dissertation Award, the Academy Health Article of the Year Award, and the H-Cup Most Outstanding Article Award. She received her PhD from Columbia University in 2008. Welcome. And I'm going to call on Sandy to begin.
Oh, thank you. Thank you, Karen, very much. And thank you for the invitation to be part of this program today. I'm learning as much as I'm sharing, and much more, in fact, than what I'm sharing. So I have worked primarily with taking care of patients' physical health, so bringing the whole mental aspect to it seems kind of a natural, since the brain is part of our physical body as well. So just for a little bit on my background, as Karen mentioned, I was part of an organization that created health IT for home care and hospice that started in the 1990s while I was still a clinician. And one of the things that we found as things went along, we were creating technology for a silo, one of the silos, and we realized in the decade and a half or two that followed our start was that they were starting to have the need to communicate with the other silos in healthcare. So we started thinking about this in about 2010 and actually started our second company to create a new technology that was built to be shared. Okay. So I just wanted to give you a little highlight of what we're working on. The technology, as I said, is really built for security and for sharing at the same time, which if you're working in healthcare, you realize how difficult that has been to figure out how you can both protect the data and also be able to share it with all the people that we need to share with, and recognize that we have to have this in an evolving environment where the technology is advancing practically as fast as the way we think about it. So we've been trying to create something that's flexible from the beginning so that it's easy to adjust as you go along. Right now what we do is we use several methods of being able to identify who's using this, and as most of you maybe are aware, most of the data sharing has happened between different clinicians. So a hospital and a clinic, or a hospital and a public health agency, or a hospital and the government are the two ends of the chain of sharing. And there's been more and more of a demand for patients and family members to have access to more data than what they've ever had before. So we've been working on the different ways of managing identity and making sure that the right people are sharing data. And this happened just in the last couple of months, and I'm just bringing this as one of the big awarenesses that's happened in our state, as we've actually had a crisis of people making more and more complaints about long-term care in our community. And in the last few months, there's been hearings and so forth about why this hasn't been adequately addressed. And one of the issues from the provider side has been that they have documentation requirements that have overwhelmed their systems, and so they've been having more difficulty with the data side of it, and the families haven't always been aware. They are starting to realize they have to take more of an interest or be able to get information more from the Long-Term Care Association or long-term care providers so that they can help monitor that and help with it. And so it's really been a learning experience, I think, from both sides, that we have needs for better information for everybody involved in care of the elderly. Oop, wrong way. And one thing that we have come to realize is that it's not just healthcare organizations and healthcare professionals that are giving care to people in our communities. It's both the formal public health, social services, and so forth that's available. Some of our community organizations, churches, synagogues, schools, and so forth. But family really plays a big part in that. And as we've noticed that adult children often don't live right next door to their parents anymore like they did in the past, sometimes it's been difficult for those children to keep the right lines of communication open so they really can be involved in in the decision making and so forth. So we've been working hard to make sure that those children can have access to the right information. And this is just a visual of how the person on the left is the mother and the person on the right is the daughter. Both of them have to have a line of communication to all the different people involved in the decision making for a complex condition, and it's been overwhelming for both the patient and family and the providers to have all those single line information flows. So what we're working on is making sure there's a place where health data can be in one place, that the patient and maybe a family member, if they want, or someone that they trust, can help manage what's in that data store, can help vet whether it's accurate or not, And then they can use that to share with a wide variety of professionals that they use to help manage that. And as Karen mentioned, we are finding that they want to include a lot more people in that than ever before. It's not just one doctor or one hospital, but they might want a legal and a financial advisor to help them with that. And it's helpful to have a complete set of information that the patient can allow them to have access to it, and there might be times where they will contribute data to that. And then there are another set of professionals that are helping with a certain aspect of it. Being a dietitian, I always had a hard time getting access to an individual's complete health information that I needed to help with them. Pharmacists also need that information if they're helping manage medications, and physical therapists and so forth also need that information, and sometimes that's difficult to get that. And if there's ways that we could help them also be able to contribute, because often they have observations between clinic visits or hospitalizations, that's very helpful for decision making. And in today's day, we use a lot more apps to be able to help the patient do stuff on a day-to-day basis. And I'm going to show you a little bit about how we put this all together. And to have a disease management app that also can contribute data to something that your providers and your advisors have access to, that's one of the things that we see as the future, and things that we want to be able to make that data store complete and usable by all the people involved in the patient's care. And then we see that the ability to actually take the full set of information, accurate information, and use that for reporting and analytics and all the various registries. That's something that we see as an ideal way of making sure that when we're doing analytics and quality reporting, we have the right information for that. So I'm going to give you a use case. I'm technological enough to know what a use case is, so I'm pretty proud of that, so I'll just say that. Where we're working on creating a system where we can help implement what is called prehabilitation for cancer surgery. And I'm sharing this study with you that showed that when patients received therapy before they had surgery, it improved their outcomes after the surgery. And so this initial study showed that the prehabilitation was more effective than rehabilitation as far as making sure your condition was good afterwards. And they've also found in studies since then that it actually reduces your chances of having wound problems, infections, shortens your length of stay in the hospital, and so forth. So this is an area where they're working to really improve outcomes for people who have a cancer diagnosis, and then the first thing they have is their surgery. So the elements of prehabilitation are exercise, where they do an initial test to see if you really are frail enough that this would make a huge impact. They have a exercise component to the therapy, nutrition component, and then they also use some psychological counseling to help you manage this during this process. And all three have been shown to be important for getting the best outcomes. So as you can see here, we have quite a distributed number of individuals and tools that will help with this. The initial primary care and oncologist, but also the surgeon is interested in having this information. Obviously the patient and the family. The dietitian's going to help with nutrition, physical therapy with the activity, and then the behavioral health is going to help with the stress management. And this is what actually happens in our, what we call a care plan manager. We actually create a plan that's accessible by both the patient and the family member that is going to be available for them, and then they can see the components of it, they can see who is responsible for it, and for every item that has additional information, there's a little book there, book icon that tells you that you're going to have more details if you click on that. So if I look at then my exercise icon, I'm going to see that I'm going to need a 6-minute walk test, and that's going to give me a little bit of information on what that's all about. And then we're also including a link to another company called Thrivers, which has digital exercise a program so that people can actually do their rehabilitation or prehabilitation at home. So we have a link right to that will bring it right to them. And this is what their tool looks like. And they have cancer patient-specific exercises that they can do right along with that gives them the instructions. They give a little rating for it. It'll record that they actually did it, and then the patient also can get some feedback on that as well. So they're looking to make this, as we go along, a better and better product for different types of conditions. So that's what they can do right away. You don't have to go and have a referral and wait 2 weeks, considering that the prehabilitation is usually a 3-week period of time, where you're waiting between the cancer diagnosis and the surgery. This shouldn't be a 6-month period of time. We want to make sure we can get these interventions happening as soon as possible. Then this also, the Thrivers also gives you a dashboard for the patient to look themselves as how well they're doing. Are they doing the exercises? Are they tolerating it? And so forth. So they can visualize it, and then it also gives the clinicians involved this visualization as well, so they can keep an eye on how things are going, even though they're not coming in to see them every day. Then for the nutrition component, what we're going to recommend is that they use a whey protein supplement, because the major goal we're trying to aim for is a 1.2 grams of protein per kilogram per day. And in order to get that for someone who probably is frail, that is going to be a challenge. So we're going to use that. And another thing that they have found is that if you actually give a protein supplement within an hour of your exercise, you actually are going to build more muscle directly. So we know that that would be the optimal way to get this additional protein, and so that's going to be part of your nutrition, and you can look in the details of your nutrition plan to see that's what you're supposed to do, with a link to the place where you can order it. And then also many times they may not be able to prepare meals as well as they could, and so here's a link to a place where you can order meals that are developed specifically for cancer, and they can be delivered for whatever part of the country you're from, and so that's another way we can help them manage this. And we can then also keep track of what they've ordered. You know, if we also get some documentation of how well they're doing with that, that would also be part of our plan. So you get more up-to-date, real-time information about how patients are doing. And then we also have on their plan that we're going to give them some instructions on relaxing and managing their anxiety, and they will have the information that they can speak directly to their team members. And so we also have one of the things that I've always found very helpful as one of the supportive clinicians was to be able to see what other clinicians are doing. So I could tailor my information to what they're doing. And so what we do is make a place for all the team members to have access to the messages so that they can understand what other team members are doing, and they can help even further to make the optimal outcome of a good outcome from the surgery. And just for an idea of how we're seeing this in the end game, is a place where we can have data available in many different places so that it's not all in one location, but that the information can be shared across different locations, but it's using some of the same standards-based ways of collecting and storing data so that it can be used again for the analytics and so forth. So just as a summary, what we're looking at is making sure that there is a richer source of information about patients for care, as I really emphasized how you use this more in real time. But for all of you who've worked with patients, you realize having that historical information will greatly enhance how we understand how patients manage at home. That's one of the things most of us clinicians have just guessed about. You know, oh, I can imagine this, or you ask, you talk, but you know very well you don't have a good idea of what's happening. And what we want to do is make sure we have a way of capturing data in closer to real time so we have a more real picture of what's happening. Thank you very much.
Are you saving Q&A for after? Okay. So as an employee of the Federal Reserve Bank of Philadelphia, as part of the Federal Reserve System, I have to say that the views expressed here are my own and don't reflect the views of the Federal Reserve Bank of Philadelphia or the Federal Reserve System. In addition, no statements here should be treated as legal advice. If you're taking legal advice from me, you've got a problem. Right? So, but before I get to that, you know, someone asked me in the hallway, and I've fielded this question a lot. What does the Federal Reserve have to do with aging, cognition, data sharing? Why are you involved in this at all? And I think there's a lot of you know, reasons to that. Some are personal, but if I just go back to 2016 and what I was thinking of, you know, back then, before I'd conceived of this conference, I'd sat and I'd listened to a professor talk about his father, who was another brilliant man, and this professor is a brilliant man as well. And the father had made all the right decisions in his life, financially and otherwise. And he'd accumulated a good amount of savings. He'd purchased long-term care insurance, and he was on a path to a sound retirement until he wasn't. And he started making investment decisions that were suspect at best. When he needed to find alternative sources of income, he decided, well, who needs this long-term care insurance? I certainly don't. I haven't used it yet. So he canceled that, and he just made a series of financial decisions that just unwound him. Now, fortunately for him, he had his sons to help, and they were able to rehabilitate him financially. But it doesn't happen for everyone. What does it have to do with anything? Well, it's economics in a lot of ways is the study of how individuals and firms make decisions. There's a lot of things that we do that are not rational and not optimal. We tend to use rules of thumb. We have all kinds of behavioral biases. Now that this water is mine, you know, I value it more than, you know, had it been somebody else's. All kinds of crazy things and framing effects. And it's interesting to think that all the work that past versions of yourself have done to put your future self into a position of financial security could be completely undone by that person, right? And so you start to think about what kind of mechanisms can you put in place, commitment mechanisms, so that that future person who may be experiencing some type of cognitive difficulty doesn't undo everything that you've worked your entire life for, because as Jason said, you don't have time to make that money back. You can't, make, $100,000 appear when that's money that you've been accumulating over your lifetime. So that's one of the reasons why I think it's interesting and applicable. I'm only going to talk about one little aspect of data sharing here, and it's data sharing between financial institutions. Right now, that's a no-no. So Gramm-Leach-Bliley was a law that was passed in the late 90s, and there's a big chunk of it that talks about data privacy, what can be done with data, what financial institutions can be done with data. And there's a lot of exceptions, and the exceptions will allow data to be shared with law enforcement, with federal, state, local law enforcement, sometimes with adult protective services. If there's any sort of court order or anything like that that a financial institution needs to comply with, data's out the door. It has to be done. But when it comes to sharing information between financial institutions, it's almost a total no-no. I'm going to talk about here one situation in which data sharing is allowed between institutions, but it's for completely different reasons, and it's part of the Patriot Act. So let's just go through this. I'm just going to go through these slides very quickly. So we've seen this, that financial institutions are on the front lines. They could monitor and detect changes in customers' financial capacity and susceptibility to financial crimes. The problem is that there's no mechanism for transmitting that information to a doctor or to any of your other financial institutions, right? I have a TD Bank account, I have a Vanguard account, we have an Investors Bank account. Just my wife and I together, we've got 10 different financial institutions that we do business with. So I have, by way of an example, think of someone who has lost money as part of a grandparent scam, and if you don't know what those are, go and read about them. But somehow, imagine that this person's bank catches the transaction, prevents it from happening, right? Now that bank knows that, okay, if we have a flagging system, we may want to flag this person, this account, and keep a close eye on it for suspicious activity in the future. The problem is that none of his own banks know. So I'm going to skip through a couple things. None of his other banks know. So he's got all these different financial relationships, right? My wife opens a new CD at a different bank every week, particularly in the low-rate environment, right? So alerting some of these other financial institutions could help prevent a loss, right? Because otherwise, the only way they're going to find out is when it happens, right? And by that point, it's too late. By the way, these losses that are borne by these consumers, if it's fraud, if they are victim of fraud and the consumer themselves transfers money or wire transfer, goes to Walmart to buy $1,500 in gift cards, once that money is out of their account, it's gone. It's not the burden of the financial institution to repay them. If you're being financially exploited by a family member and they take $100,000 out of one account and they take $50,000 out of another account, the only way you can get that back is through litigation, right? Court proceedings. You can't. The bank is not responsible for this, so it has dire consequences for the consumer themselves and their family. Now, part of the problem here is that in a lot of situations, if the person at the center of this hub, Joe in this example, can't be counted on to convey this information to his other financial institutions, hey, I was almost a victim of fraud, Can you, keep an eye out for me? Sometimes people aren't willing to admit that it will ever happen to them again, even if it has happened to them. You're creating a hub and spoke system where that hub itself is kind of really wobbly and shaky, right? So the person at the center of that hub may not be the right one you rely on to disseminate this information. And you could even have a trusted contact. In this case, it's Bill Gates, who's my trusted contact. It's Joe's close friend, Bill Gates. But guess what? As Jason said, 70, 80, 90% of the time, financial exploitation is committed by a known person, right? So that includes family members, close friends, new friends that arrive, out of the ether. And you never know. So unless Joe has opted out of his data privacy rights, and this is coming right from Graham Leach-Bliley, his bank, that bank that first identified the grandparent scam, can't alert any of his other financial institutions. It's a no-no. So what are we talking about here? Well, we're talking about creating a data sharing system that could operate on Joe's behalf such that you don't need a strong hub. You don't need to trust that hub. And I have this picture up here is a little bit misleading. But the idea is that any of these institutions can talk to any other institution, share notification information, say, listen, here's the person, this is the type of thing that occurred, right? It's under investigation, so it was a potential fraud, it's under investigation. And we just want you to be aware of that. And then all those other banks can retrieve that information, bump it up against their client base and say, look, this is a client of ours. What steps can we take? And of course, they need to have processes in place. But without the system, they don't have processes in place, obviously, to address these things. But there are actions that they can then take before financial exploitation occurs. And one of the things that we learned in studying these issues, particularly financial exploitation, and that it just doesn't happen the financial exploiter just doesn't take money out of one account. Once they take money out of one, that they get bold and they'll take money out of more than one, right? They'll move money across accounts. They'll set up a joint account, move money into a joint account, and then move money into their own personal account from the joint account. The money's moving all over the place. So, if in the future, Joe becomes susceptible to one of these scams, and there really is this Nigerian astronaut scam. One of the things so this astronaut he's in space for 10 years and he needs to come back home, and he needs obviously money from this person. This is totally absurd, right? People fall for it. It's totally absurd on purpose because it screens out anyone who isn't at the point of they have enough of their faculties together where they may not fall victim to the crime. This is looking for and this is, I shouldn't say this, but it's looking for the worst of the worst, the sickest of the sick. The people who, will fall victim to this are going to give them their money, and they're going to lose a lot of money. So they are absurd for a reason. Obviously, there are risks to data sharing. There's data security. Now you've got a whole bunch of data, personally identifiable information. It's residing someplace else where we don't know. We haven't talked about what type of system this would be. There are risks in oversharing data. There's risk of inaction. And this is where I've heard from a lot of the banks, well, they say, well, I'm not sure if I want this information. I'm not sure if I want to tell you this because what if I have this information, it now becomes discoverable, something happens, and now, the prosecutor is saying, well, you had this information, you did nothing, you could have prevented this, right? Now the liability is on you, right? And a lot of it really comes down to money. Having this sort of system too would be costly for other reasons. But there are a lot of risks involved that would need to be talked through. So I mentioned the Patriot Act. So FinCEN is a really interesting organization. They have something called a secure information sharing system by which banks can speak to each other. They're permitted to speak to each other in matters of anti-money laundering, suspected terrorist financing, right? So things that are a threat to national security. And that's good. I mean, fortunately, we do have that type of system. They also have SARS reporting, suspicious activity reports, and since 2013, there has been a checkbox for financial exploitation. So they're keeping track of data on financial exploitation when it is reported to them. So they've got a data sharing system. You know, they've got a means to allow financial institutions to share information for, you know, across each other. They've got an electronic form that says, you know, elder financial exploitation. They're just not using them. And this is one of the most, you know, this is really blatant. This is just, it's right in front of our faces. And if we could just repurpose a couple of things, the federal government could be the one performing this service for us, not the Federal Reserve, but the federal government. But it's not happening. But there are ways to go about doing this. It would probably have to occur on an opt-in basis. That is, you know, I think it would be really difficult to pursue legislative changes to Gramm-Leach-Bliley or anything else that would permit banks to share information between each other, because there's a lot at stake, right? But if you think about consumers opting in to have their data shared, opting in to have, you know, someone looking out for them who they can trust because they are independent, it's a, you know, a service that they are, you know, they might be paying for in some cases, but that's really what they need. And that's really the end of it, right? So thank you. There's a lot more to be discussed and talked about, but clearly there's an opportunity for banks to share information in order to help prevent losses from financial exploitation and fraud.
Thank you. I'm just going to be following up on some of the discussions we've been having about kind of the potential of using some of these alternative sources of data and talk about the very early stages of a project that Joanne Shu and I, who's also at the Federal Reserve, so same disclaimers that Larry mentioned are going to apply again here, are working on. So we, in the Grand Rounds theme, also have no conflicts of interest to disclose, but funding from the National Institute on Aging and the Social Security Administration. So again, we're not representing their views either. As we've sort of covered extensively at this point, early signs of cognitive impairment can manifest through things like missed bill payments, erratic and uncharacteristic financial decisions, and sort of, as we've been talking about, financial fraud, questionable asset allocation, and credit delinquency. Wrong way. So anecdotally, we think these things are pretty common, right? 84% of surveyed Fidelity brokers think that they have at least one cognitively impaired client who's asked them to do something pretty questionable, and they've had to go ahead and do it. And we've seen in the popular press a lot of very large-scale losses being the trigger for diagnosing cognitive impairment. Unfortunately, we don't have actual numbers between how many older adults are actually affected by these adverse outcomes and how large these losses really are. However, that's knowable from some existing sources of data. We've used some large national survey data, the Health and Retirement Study, to look at the links between financial characteristics and cognitive impairment. So we look at 3 groups of older adults: those with normal cognition, those who report a new cognitive impairment, and those who have been cognitively impaired for 2 or more survey waves. This is a biannual survey, so this is 4 or more years. And as you will see, as cognition gets worse, you are more likely to report having a new difficulty managing money. You're actually less likely to report new debts, which we think is driven by family members taking over and assisting with financial decision making. And so while there are these non-trivial levels of financial difficulties being reported, we are not at sort of a one-to-one relationship where we say, oh, well, we see a difficulty managing money, that must imply cognitive impairment, right? And we wouldn't want to use these sort of gross diagnostic characteristics. We need much more specific information if we're going to be able to sort of inform patients that this is something you want to be concerned about. When we put a number of these characteristics together in predictive models, we note things like a new difficulty managing money increases the probability that you're have a new cognitive impairment by 5 percentage points. So this is statistically significant. However, it's again only a relatively small increase in the probability, and it could be very alarming to be told this might be a cognitive impairment diagnosis without a lot more information. So how could we improve the quality of these models? By bringing in a lot more data. So what we've started to work with is using consumer credit data, which is real-time, large-scale flows of information about a number of consumer events that could be potentially tied to dementia, right? So we now have a way to see late bill payments, things 30, 60, and 90 days delinquent, tax liens, are you forgetting to pay some of those things? Has your home been foreclosed on, again, because you might be failing to pay a mortgage? Are there changes in your borrowing patterns? So are people making credit inquiries in your account or in your name, even if new accounts aren't being open? Is there a sudden change in the amount of credit extended to you because your Nigerian astronaut has a new credit card and finally bought his spacesuit? And credit usage. So these data are already being used for a number of purposes by financial institutions that may also have legal responsibilities around some of these financial decisions and dementia. Oops, sorry, that's the wrong direction again. So in large national data sources of credit data, we see that many of these fields are being actively used by older adults. There is variation and opportunities to kind of look at the extent that combinations of these variables might actually be highly predictive of cognitive impairment. So given what we know about the probability of difficulties managing money increases with worsening cognition and patients' frequent inability to detect these problems on their own, we think there's sort of a strong case for using some of this financial data and testing the extent that we can do predictions on our own. So we've, for the past about 18 months or so, been in a data request process with CMS to obtain the Medicare claims necessary to link to credit report data and start working on these predictive models. And we're sort of very eager, not only on the research team side, but with support from NIA and Social Security, sort of very interested in talking with everyone here about what we can do to sort of expedite this type of research and work with CMS to sort of think about ways that we can gather necessary information to kind of identify some of the patients who might particularly benefit from both greater access to cognitive screening and medical services, and also sort of thinking about the other government policies. For example, Social Security has a representative payee program that can be used to identify a responsible individual to receive benefits on behalf of someone who's cognitively impaired and may not be able to use their benefits. So kind of developing a system that could talk between both government institutions and financial institutions, as Larry's mentioned, could have a lot of benefits for both patient care and protecting patients and their families from some of these catastrophic losses associated with cognitive impairment.
Well, thank you very much. I think that those were some really interesting ideas that everybody has shared, and I think that it sort of rounds out the discussion today. I just want to ask if anyone in the room has any questions? No? Okay. Is there a way to find out if there are people on the YouTube channel or on that called in that have questions? I just don't want to cut anybody off. Oh, Mike, you're going to ask a question? Yay!
Well, it's rare you get a panel that has much knowledge. I was just curious if anyone has experience with dealing in a situation where a family member doesn't have cognitive ability to make their decisions and then getting either a court order or someone to intervene, and kind of what's the tension there in terms of actually finding someone to be not able to take care of themselves, and then is that an easy path to follow to get intervention, or any experience with that or thoughts? Bad question.
I mean, on the sort of documented policy side, it's not particularly easy, and there's been, again, this is something we know more anecdotally than from sort of national research studies, but concerns about fairly corrupt systems in some places that are leading people to be incorrectly classified, taken from their homes. So we also run the risk of needing to improve the guardianship process and programs.
Right, I know I'm introducing a whole another aspect to it, but maybe it's another piece of the discussion, because I do think it does come into play, family members that want to maybe take an advantage of someone and those kind of things.
Yeah, there's a lot of discussion in the financial services industry about power of attorney, the good and both the good and the bad aspects of power of attorney. So now, obviously, you don't want power of attorney to turn into a license to steal. So that's one of the downfalls. There's also something called a springing power of attorney. That means that you don't become power of attorney until a doctor has said that your family member is now incapacitated and there's a medical diagnosis. Obviously, from a financial perspective, what we've been saying is diminished financial capacity comes first, right? So that doesn't help you when you're trying to prevent financial losses. It's too late by then, right? So there's a lot of talk about how to use powers of attorney. Some recommendations, people have recommended to have more than one power of attorney, sort of a joint power of attorney. That can create its own problems when it comes to making decisions, right? I know if it was my brother and I, there would be some problems. But one of the things, and I think we've heard this from some of the biggest banks and brokers, and I know Merrill Lynch is thinking about this, preparedness is really important. Having discussions from a financial institution perspective with your clients in their 50s, even in their 40s, about having emergency contacts on their account, right? Having a power of attorney lined up. Sometimes there is a need for an accountant or a financial caregiver, right? Having those things in place beforehand, prevention is sort of the best medicine there.
And then a follow-up maybe to that. One of the things I think, about having those discussions and being understanding, like your options. You talked about opting in to having your financial information shared. I mean, I feel like I'm a privacy person, right? I would read those notices, but I have to say, when I look at that, I think that it's going to be about marketing. I'm going to get bombarded with marketing. I'm not thinking in terms of the good. So it sounds like there's an educational opportunity here as well, in letting people know that these options are available and what they can, how they can help.
You're right. There's a big hurdle. There is a big hurdle to that, and so one of the thoughts was that if there were this type of information sharing system, people could opt into it at the same time as they're opening up a bank account, right? So it could be a service that's offered perhaps for a fee, or some sort of graduating fee, but. There are a lot of questions that are asked right up front, and one of the questions that we've learned that brokers and brokerage dealers, some have asked, now as of February 5th, they have to ask is there anyone that you would like to designate as a trusted contact? And anecdotally, what we hear is like more than half the time, people say no, right? And I think it's about trust, it's about financial independence, right? But I think when you're opening up an account, in particular, the default is, I don't want anything extra, just leave me alone. Just let me open this account. This account is for me, and those considerations are future considerations, and I don't want to worry about it now. So there's obviously there's a marketing or sales aspect that would need to really get through those hurdles, right? Those things that people think about when they're going through the process of opening a bank account, which can be difficult for people mentally. It's a little bit trying.
Hi, my name is Monica. I'm a privacy enthusiast, and this might be a question for both of you. So what is the answer, if you could have the answer, Dr. Karlawish, or, to get the financial institutions to make anyone coming to a neurological assessment to share some sort of level of information, realizing that there's probably a million fights to fight to get you that? And what's maybe the first baby step? Something that came to mind is maybe life insurance policies require that when you sign on, you also have to share your financial decisions. And as they see you stop making good cognitive decisions, they could say, look, unless you dedicate a trustee, then your rates go up, and maybe that's a private sector kind of tweak that can be made to get people to think better. And so I'm interested to hear what each of you might think what is the solution, and what would you want to maybe win and get you what you need?
I think it really it comes down to the customer, and consumer demand. And the more we've thought about this, the conference was focused on educating the financial services community, bringing in doctors, having Dr. Karlawish and Dr. Boyle and others talk about really what's happening in the brains here, right? This is a real problem. It's a tangible biological problem that has financial consequences that affects people's quality of life. But the more I think about it, policy changes are very difficult to enact, things change all the time, and Washington is very fickle, and you can't determine that. I think what you really need is for consumers to demand this service on behalf of their financial institutions or third parties, right? There's an opportunities for third parties like EverSafe to provide this monitoring service on their behalf for a fee. And I think that's where it starts.
So if I had to think, you asked me, so I'll provide an answer. Think forward to, so the United States has a national Alzheimer's plan. It was one of the few bipartisan acts of Congress passed in the last administration, was signed into law by President Obama. And it's a very substantive plan with 5 goals and a host of strategies and tactics. And goal number 1 is that by 2025, we will effectively prevent and treat Alzheimer's disease. And by the way, Alzheimer's is defined as not just the disease Alzheimer's, but as an umbrella term to capture the other causes of cognitive impairment that I mentioned. It's a moonshot kind of goal by putting a date, very much akin to Kennedy's, but before the end of the decade, a man on the moon and bring him back goal. And there's a role for those kind of things to motivate action, otherwise people just kick the can down the road. So whether it's 2025 or not, we could set aside. And so, for example, I can tell you now in America, there are a variety of studies that are enrolling older adults who learn a genetic and or biomarker result that suggests they have a higher risk than if they didn't have that result of developing cognitive impairment, typically Alzheimer's disease, and then testing a variety of drugs in them, just like we did with statins in the 80s, for example. And the rest is that story. So imagine that one of those studies works. Imagine that we achieve that goal, whether it's 2025 or 2028 or 2030, but imagine we do. So what I would be doing then, and my colleagues, is someone at 60 would come in to see their doctor, and they would potentially say get a ApoE test, a gene, and based on that result, they were at a higher risk of getting Alzheimer's, so then they would go on to get a brain scan, because you're going to tier this, and that brain scan shows that they're having emergent changes, and then they go on to a drug, and well, what I would say, that would be, to me, what we would almost call like a perfect moment, if you will, to say, well, now we need to not only just come in and take this drug every month or whatever it's going to be, but set up a system to plan that, short of a cure, you could develop cognitive problems. And so, for example, have them enroll in a system where their financial transactions are aggregated and monitored in the way that Larry laid out with his vision, opt into that. My hunch is that their spouse would be interested, or their partner potentially as well. Their adult children might become interested because as well in that. So I think that would, to me, strikes me as a kind of a sound model to say, you're at a higher risk of having brain problems down the road, and go forth and flourish and live independently and autonomously. But if something should happen, what's the system in place to detect that? And that seems like a nice, tight, sensible system that would be my vision of a future.
And they would have given their consent too, so the privacy concerns.
Yeah. No, obviously, yeah.
So I just want, I don't mean to cut you off or anything, but, and we can continue the conversation. I just want to make sure that if anyone's on the lines are unmuted, and so if anyone has any questions that are on the, from people that are on the phones, they can feel free to ask. Go ahead. I don't think so.
So, Sherry Ling, and thank you for the presentations. And this is more a comment rather than a question, or maybe it's a question. I don't know. As we're thinking from a clinician's perspective, one of the potential barriers that we have faced there are many, but in actually detecting that there is a problem or someone has, limited cognitive ability or has some cognitive impairment that is yet to surface, has been that the reality then, okay, so what do I do about it, right? And we have tended to think in a very medical model, which is, so we're looking for that drug that would fix the problem and halt whatever this is, dissolve the cotton candy between the synapses, right? But, what I've heard today really causes me to rethink the actionable opportunities, and that the actionable opportunities may not be in the here and now just medical, right? But it is, so, what tools could we as clinicians have at our disposal to not to have the complete conversation, but just to point people in the right direction, to start thinking about the implications for their futures for planning purposes. We think about planning, care planning, like what do you want in the case that your heart stops? But this is in the here and now and has a downstream impact on their ability to sustain themselves and for our system to be able to withstand what is ahead. So just observation, and if you have thoughts on what it is that we as clinicians could present our patients with, and how we think about this differently. Really open to suggestions.
I think there's a few pieces of it. Part of it is thinking about how we can better sort of get some of our financial data and algorithms together to use that in the diagnostic piece, and bringing in those data in the beginning. The other part, and I think listening to you speak, it makes me think of the struggle to introduce advanced care planning as a Medicare benefit, and this is yet another area where sort of thinking about who the best person is to be meeting with the patient and doing the education and how to pay for it is probably a little bit of a policy struggle, right? And this could be another sort of healthcare adjacent area that I think is going to be increasingly important kind of as we have this population growing with cognitive impairment and a lack of sort of actual medical treatments to cure it that we can offer at this point.
I mean, go ahead, Jason. The model that you described, I think the model that was described there for rehabilitation for individuals with cancer is inspiring on a number of levels. First of all, one could imagine the same kind of thing being done for someone who is older and either at risk or showing signs of cognitive changes. You could imagine a similar setup there where the issues, some of them would be the same, of the interventions, but you could imagine things like, are your finances in order, meaning if mistakes occur, does the bank know who to call, for example? So it took me 6 months to get all of my father's banks lined up to let me be called, and one still won't do it. They still just, I have to be his guardian, they think, and it's just like, we're moving the accounts. But the other thing that was inspiring about yours was it was about cancer. And I think the history of cancer in the United States is once a problem was framed as cancer, you have a comprehensive cancer center with access to all these ancillary things. Our field, aging, has still struggled with the moment it's not a biomedical framed thing, it's a social service. Well, if you're poor enough, maybe someone will step in and provide it for you. And yet we know that, but if it's cancer, we'll give you access to mindfulness therapy and whatnot at the Comprehensive Cancer Center, paid for out of insurance. But I think we might be able to make that pivot if you frame it around Alzheimer's. And I do find that one thing that rallies all sides of the aisle for things like the CARES Act and whatnot is if it's about Alzheimer's. And I think that becomes the entryway to address these larger issues that cut across diseases of aging, is to frame it around that disease.
Can I ask a question at the same, that's kind of related to this? It seems, even as someone who worked more in the clinical area, that money was an autonomy issue more than physical health. That like if you're older and maybe have some frailty issues, you were willing to let people help you with your health, but like money was, oh, if I let somebody help with that, it means I'm not capable, and it says something about me. And I was wondering if attitudes are changing about that, or if maybe we're kind of trying to get it so that people are more willing to consider help a good thing.
Yeah, and I'm glad you mentioned the autonomy issue, and from a clinical perspective, where we see it in dementia clinic is that conversation about driving, right? And where it has been helpful, what has been helpful is, number one, the consequences of not picking up a problem and not having that conversation are devastating, right? Not just to the person, but the community. So what that has led to is the work that has been able to help us identify what exactly the risk factors are. You know, age is not sufficient, right? The fact that you get lost in your neighborhood, if you have foot problems, you have neck arthritis, you know, and you've had an accident before, those are signals that, you know, we as clinicians say you really shouldn't be driving, or if they're on the fence, go and get a test, a driver's test, and working with family members for those strategies where those conversations don't go so well, right? unhook make the car keys less available, those kind of things. But I think there are many parallels that, the impact of what was discussed here is really important to the people that we serve, and yet we have to be able to connect the dots that this is about health and this has implications for illness management, and because it is all about the person. These are different aspects of the person that we have to take care of. So thank you for mentioning that.
I don't know if this is related or not, but you talked about what clinicians could do or doctors could do. So there's two things that I wanted to mention. One, two economists, Olivia Mitchell and Anna Maria Lusardi, have done a lot of work developing modules to test financial literacy, to test financial capability, and a lot of the work is really eye-opening.
Well, I know Ruth is here, and I think folks.
I think that was just a random. Go ahead.
So there's an opportunity to build on that literature in a really specific kind of way. So I go to my doctor, and for my annual checkup, and now that I'm in my 40s, there are things that they check now that they didn't check before. But nobody ever, checks my cognition, and it could be as easy as, sending me a link through the MyPen Medicine network by way I communicate with my doctors and things like that.
We're just able to get on. We're having
to take one of those exams, and not only to take the exam, but to do a peer comparison, which there's another body of literature that shows that people care about how they're doing relative to others. So if I take a test and I see that, relative to other people, I'm performing not as well on these financial literacy, financial capacity tests, that may be an opportunity to, one, identify that there is a problem, and then two, convince the person that they need some help. You're welcome.
Picking up on a point raised, this really all is ultimately about autonomy. It is. Mind you, it's a very much of a late 20th century value. When Auguste Deter was diagnosed with Alzheimer's, she was a subject of a Kaiser and couldn't vote. Women weren't allowed to vote in Germany then, and actually across the pond here, not until 1920. And you could run down the list that the problems we're talking about reflect a value that's only been in the last 50 years widely held by all adults, regardless of gender and race and all the kind of status-based categories. Having said that, the point is well taken that money is one way that we often have to sort of assert our sense of self and autonomy. But one good way to lose it, autonomy, is Alzheimer's. And so I think the pairing is very nice, actually. I think it's the one way to get people to have an aha moment, which is, oh, you know what, you're right, I really don't want to lose my autonomy, meaning I don't want to lose my money, but I don't want to lose my mind, because if I lose my mind, I'm going to lose my money. And so I think that's the sort of way we have to kind of think about empowering and educating and raising awareness, is that's I think the secret link, the secret sauce.
Well, I think that if those are the questions and everyone's satisfied with please feel free to reach out if there are any further questions. Clearly, it's a conversation that filled up 3 hours this morning, and we could go on. But thank you, everyone, for coming and joining. Thank you, Dr. Ling, for supporting us. And thank you. Have a good day.